It's a pleasure to be here in this session sponsored by Visionix, talking about the diagnostic performance of Visionix VX120 Plus platform for dry eye screening. I'm going to show you our experience and our studies with this very helpful platform for our clinical practice and even training with the students. These are my disclosures. First of all, I would like to make an introduction to the VX120 Plus with the dry eye module. This platform is a combination, is the result of the combination of several technologies. Harman barometry, providing ocular barometry, the simulation of the point split function, and the simulation of the retinal image. The use of Placido-D-based corneal topography, allowing to obtain different topographic maps of the anterior surface, geometric parameters as sphericity, and the barometric analysis of the anterior corneal surface. In addition, we have a simple camera allowing to make a pachymetric analysis. We have also an entonometer, a pupillometer, and the dry eye module, which is the objective of this presentation. Regarding the topography and barometry of the anterior surface, we can say that this Placido-D-based system contains 24 rings projected onto the corneal surface, allowing to measure more than 100,000 points in an area from 0.33 to 10 millimeters. And it's very important to say that this module has been scientifically validated. We have performed several studies to investigate the precision and reliability of this technology, finding very significant, very good coefficients of repeatability of the measurements of different topographic parameters, and also in terms of anterior corneal aberrations, with a level of within session standard deviations very low, and confirming the usefulness of this tool for the practice. Regarding ocular barometry, it provides in 0.2 seconds measurement of the spherocylindrical refraction and high-order aberrations with a measurement of 1,500 points, all in 0.2 seconds in an area from 2 to 7 millimeters in diameter, allowing to cover the normal range of refraction of the eye. It's important to say that these measurements have been also validated. This is one study conducted by our research group showing also a very good level of intra-session repeatability with, for example, for the sphere, the level of error between repeated measures is only 0.05 diopters, which is completely acceptable and very, very good. And in terms of high-order aberrations, we provided this analysis with, you can see here, level of intersession repeatability below 0.05 microns. And you can see here that for a pupil size of 5 millimeters, these are the range of normality or how the measurements can range in the normal population. Also, with the collaboration with the Hadassah College from Israel, we make this comparative analysis between subjective refraction and the refraction provided by this instrument. As you can see, measurements in most of cases were not statistically significant, showing that the level of interchangeability was very strong, only with a trend to higher level of variability for the higher levels of spherical refraction in negative, it's normal. And you can see here the differences in terms of sphere and in terms of spherical equivalent, showing that in most of cases are within plus minus 0.5 diopters, which is completely acceptable. Okay. Regarding the same-field camera, it uses 455 nanometers wavelength blue monochromatic light, allowing pachymetric measurements with a resolution of 1 micron in a measurement range from 150 to 1,300 microns. Also allows measurements of the iridocorneal angle with a resolution of 1 degree. This has been also evaluated and investigated in another study conducted by our research group, showing a level of repeatability, especially for pachymetric measurements, which is extremely good. It's comparable and even better to those provided by other instruments that are available in the market. Even we make a comparative study with the Sirius system, with another same-fluid camera-based topography system, showing that the measurements of central corneal thickness and keratometry were interchangeable with those provided by this instrument. Regarding pupillometry, we have also the possibility of measuring the pupil size in all these conditions in a very short time. Scotopic condition, low mesopic conditions, mesopic and photopic, and allowing to make a dynamic analysis of the pupillary changes. Okay, this measurements of pupil size has been also validated in another study. This was published in 2020, in which we confirmed that the repeatability of pachymetric measurements were completely acceptable and very good in comparison with other instruments. What happens with the dry eye module, which is the objective of this talk? It's a very interesting module providing a measurement of the non-invasive breakup time, an analysis with photographs, very good photographs of the conjunctiva, cornea, and eyelid margins. It allows an analysis and measurements of the tear film meniscus, and with the use of a modified version of the F-ROM scale, you can grade different ocular signs that can be present in dry eye. And as happened with the previous modules of this instrument, it is also scientifically validated, as I will show you afterwards. This is the measurement provided of the non-invasive breakup time. It provides you the video of the capture of all the recording procedure, a color map showing how is the distribution of the breakup time, and a graph of the breaks that are happening over the corneal surface during the measurement procedure. It's interesting because it provides two measurements. The first nibud, which is the time point when the first distortion of the rays projected on the cornea occurs due to a tear film breakup. This is interesting, and sometimes we can say it's comparable to the classic version of the measurement of breakup time in which we use fluorescence for making the measurement, but in an invasive way. Regarding the nibud, 50% is the time when half of the subareas of projection presenting distortion was present. And these parameters, I will show you afterwards, is especially interesting. I can tell you that there is a certain correlation between breakup areas and corneal zones with staining, because these areas are areas of dissipation, and you can check sometimes. And when you detect that there is an area in which the nibud is broken very, very, very easily, when you go to the slit lamp and you can find in these areas, probably you will detect some level of corneal staining. This is our experience that we have published with this instrument in terms of analysis of reliability. This study was conducted by our research group, and we confirmed that the level of repeatability of nibud measurements for right and left eyes of a sample of patients was completely acceptable. You can see here, and even we define a potential range of normality that I will show you afterward, that has been refined with a more complicated analysis that we have performed afterwards. But this could be considered as levels or numbers that should be considered when you make a screening with the device. And it would below 5 seconds is abnormal, and an e-good 50% below 6.5 seconds could be considered as a suspect that something is happening in the ocular surface. This is the study of interchangeability of the measurements, and we can see that the interchangeability are very high, especially for the second and the third, when you make a repeated measurement between especially the second and the third measurement. Regarding the third film meniscus, is, as you know, is another parameter which is very useful in clinical practice in the area of dry eye, because it's an indirect measurement of the tear film volume, because you have to consider that among 75–90% of the tear film volume is located on the inferior meniscus. And it's extremely reduced in patients with dry eye, and even has been shown that it's correlated with the breakup time. In our repeatability study, we've confirmed that the measurements of tear meniscus are quite repeatable, with a range of normality over 0.20 millimeters that can be considered that's a suspect of a problem of tear film production. Besides the measurement of the breakup time and the tear film meniscus, we have the use of an adaptation of the F1 scale to evaluate different ocular signs that can be present and that are related to the presence of dry eye, as such conjunctival redness, limbal redness, blepharitis, and meibomian gland dysfunction. It should be said that this scale was initially developed for grading the complications associated to contact lens wear, but afterwards it has been used and adapted to the grading of different complications and problems of the ocular surface. But it's important to say, if this scale was initially developed for contact lens practice, it can be used in contact lens practice. It's specifically useful because it seems that the dry eye module is only for patients with dry eye. No, it's a very, very good device to be used to follow how is the contact lens prescription and how the contact lens wear is going on. Okay. This is the different levels of grades of the modified scale of Efron that is used by this instrument. We have normal, trace, mild, moderate, and severe for these four aspects: conjunctival redness, limbal redness, blepharitis, and meibomian gland dysfunction. For example, in this patient, it's a very good patient. In this, we can see that the level of conjunctival redness is absent, and the level of limbal redness also is absent, because there is no problem in this patient. I will show other cases with problems, but this is a very good case. And once you have finished all these measurements, you have what for me is very, very, very useful is the screen with all the information in an integrated way. You can see here for right and left eye, the breakup time, first breakup time and average breakup time, the tear meniscus measurement, and the scale of the ocular signs, even with colors, to show you that when you have a warm color is something where is a warning, there is a problem or potential problem. Okay? Perfect. I want to show you now, I think the platform is now very clear, but I want to show you that this selection of tests in this dry eye module is performed in a very comprehensive way. It's not a question of, I have included this test because, okay, they are very attractive. No, everything is done in a rational, according what is needed for a good dry eye diagnosis. All of you know that how is the definition of dry eye. There was a classic definition of dry eye that has been substituted for a more complete definition of dry eye according to the DIUS 2. stating that, and this is very important, that the dry eye is a multifactorial disease of the ocular surface, and the most important thing is that it's characterized by a loss of homeostasis of the tear film, accompanied by ocular symptoms, in which the instability of the tear film and the hyperosmolarity of the ocular surface, the inflammation and damage of the ocular surface are present, but also neurosensory abnormalities are going to play some etiological roles. It's important to have in mind that we have the activation of two central mechanisms. Hyperosmolarity, we are not going to measure osmolarity, but we can measure the consequences of this hyperosmolarity. When you can find hyperosmolarity? When you have an aqueous hyposecretion or an excessive evaporation of the tear film. This condition causes inflammation and damage to the ocular surface, ocular redness, other problems in the ocular surface, with the release of inflammatory mediators such as cytokines or MMPs, the death of the surface epithelial cells and the generation of the corneal staining, causes symptoms, and initiates the presence of compensatory mechanisms of dry eye. But there is also another mechanism which is completely related to the hyperosmolarity, which is the presence of instability of tear film. It's very funny because this condition is secondary to hyperosmolarity, but also contributes to hyperosmolarity, and therefore is a vicious cycle. And we have to break with a treatment this vicious cycle to avoid the progression of the disease. We can say two main types of dry eye, although in most of cases the condition is mixed, combining both components. But we have the hyposecretory dry eye, in which there is a deficiency of the aqueous tear. In this condition, the symptoms is the presence of irritation, foreign body sensation, itchy eye, that is worse at the end of the day, and especially worse in situations of greater tear evaporation. How to can detect this condition? With a decreased aqueous tear production, with the classical Schirmer test or other ones, a decreased tear meniscus, we can measure it with the VX120, and the presence of damage over the corneal surface. Normally, it's measured with stainings, conjunctival or corneal stainings, but this is invasive. And with VX technology, we're avoiding to be invasive. We can analyze the pictures obtained of the ocular surface, but without introducing any substance on the eye. Regarding the evaporative dry eye, in which we have an excessive tear evaporation, we have also irritation, foreign body sensation, itchy eye, with the same sensation during all the days. It's different, or even worse in the mornings, not at the end of the day. It's also worse in situations of greater tear film evaporation, and here we can find the decrease of the breakup time that we can measure. We can also detect the signs of meibomian gland dysfunction and damage over the ocular surface, okay, which is the representation of the ocular surface disease. Therefore, for the detection of dry eye, this is the combination of tests that we have to do. Please think about it. Do you think we can afford to make all these tests to all patients enter into our consultation? It's impossible. But we can make an efficient screening of some of these aspects, telling us, David, you need to make more tests, or not, or it's enough, and this patient has no problem. Regarding the evaluation of the tear film with the VX, we can evaluate the quality because of the tear film, because we measure the breakup time, but also we can measure the quantity with the meniscus scale. But also we measure the tear, what is the damage over the ocular surface, because we can use grading scales of the ocular redness. Okay, with this combination, we can have an idea of what's happening on the ocular surface, and even we can have an idea if there is more component of evaporation or hyposecretion. Okay, because evaluation of the tear of hyperosmolarity is a very complex evaluation and expensive. And the symptomatology with a validated questionnaire as OSCE, I recommend to do it always. This is a very easy task, and you don't need any instrument. You only need to fill the corresponding question. Okay. Regarding the non-invasive breakup time that we have shown before that we can measure with the VX, it's important to say that in this case fluorescein is not used, and we can measure the tear film stability according to the alterations that are occurring in the miles projected onto the cornea. Some authors have reported that Niwood's values are lower than those measured with fluorescein, but others say the opposite. I think it's very difficult to know. But what is true is in dry eye, normally, Niwood is somewhat higher than the good measured with fluorescein. Therefore, we cannot extrapolate the cutoff points defined in the literature for fluorescein with those that we have to define with this instrument. There are, with other instruments, different types of Niwood's cutoff points that have been defined, around 8 seconds in this case, or 5.9 for another instrument. For example, here you have with different instruments 2.65, another one 6.2, another one 6.3. It's very variable because it depends very, very significantly on the how this rupture of the mice is performed. It's true, and you have to consider that although the use of the Niwood can be very sensitive to detect dry eye, it's not very specific because you need more tests, but it's good for making a screening. Regarding the tear meniscus, something similar. There are a lot of literature on that, but here we can say it's more consistent because most of the studies shows a value around 0.20, 0.22 has the limit in which a patient can present a dry eye or not, even somewhat lower in some cases. Therefore, it seems very similar to what we have found in this in our study with this platform, with the VX120. And regarding the Efron scale, we have used, because the Efron scale has a lot of signs that you can evaluate with different pictures and with different grading, normal, trace, mild, moderate, and severe in all cases. And you can, according to the pictures, that you can see perfectly the eye of the patient or all the features of the ocular surface. You can make the patient to look at one position to other. You can detect and make a precise, we can say, evaluation of these ocular signs that you can find in these patients. Okay? Perfect. Let's go then to the diagnostic performance. We have proposed several parameters, Niwood to breakup time, tear meniscus, some values that can be approximately useful for the detection of dry eye. But we have performed a more comprehensive study in our clinical practice that I hope is going to be published very soon. At least we have the first positive review of this investigation, and we have tried to define exact cutoff values for the non-invasive breakup time. This was a study developed in the optometry clinic of the University of Alicante. It was approved by the ethics committee of our university, and the inclusion criteria were adults with corrected distance visual acuity of 0.10 logMAR or worse. And we created two groups, the dry eye disease group and the control group. The clinical diagnosis of dry eye disease was performed according to the following criteria: an OSDI, a symptomatology of 13 or more, and at least one eye meeting at least one of the following criteria: a Silver 1 test without anesthesia lower than 10 millimeters at 5 minutes, a tear film breakup time lower than 10 seconds, and grade 1 or higher in the Oxford scale of corneal or conjunctival staining with fluorescein. This is to be sure that we are in front of a real case of dry eye. Exclusion criteria were no history of ocular pathology different for dry eye disease, no history of ocular surgery in the previous month, presence of corneal alterations that could influence the study results, and we try to avoid those patients taking chronic medical treatment with drugs such as anti-inflammatory drugs or antihistaminic drugs or drops or whatever. And our objective was to make this comparison between the classical method of measuring the neighborhood in an invasive way with that performed in the with this new technology provided by VX. Okay, and we make the comparison, but in this case with the certainty that we have patients with dry eye and we have patients, normal patients, because we have performed a very detailed analysis in all cases. Here you have in the superior part, for example, we have a patient that we can have doubts because we have a first nibud of 5.1 seconds, but the average nibud is 9 seconds, and you can see that the tear meniscus is 0.23 millimeters. We can say we are in the limit. And in this case, there is some level, a trace level of conjunctival redness in the right eye and a level moderate of blepharitis in the left eye. This was a case that, in this case, this patient was considered as normal. They have no symptoms, but you can see that it is in the limit of what we can find. In the lower part, this is a patient that can attend to your consultation, and you can think that is a normal because this patient wants a refraction only, but you can see that the first nibud is only 3 seconds. The tear meniscus is clearly good, 0.26 millimeters, 0.31, but this patient has a mild level of conjunctival redness and a trace level of meibomian gland dysfunction. It's clearly an evaporative dry eye. There is a suggestion that can be, but this patient has symptoms. Therefore, I have only to make a refraction. What do you think? No, it's telling you the instrument. This patient needs a comprehensive analysis. In the other case, which is in the limit, probably you can doubt. Some of you will do a complete analysis to be sure, but other ones says, okay, we can make a checkup in 6 months because it seems that everything is okay, but we have some suspect. Okay, it's up to you. But you can see how helpful can be the device according to that. Regarding the scales, these are cases from our study. The superior case is the patient that I have shown the first breakup time and tear meniscus results. You can see that everything is normal. There is no signs of conjunctival redness and anything. But for example, in the other eye, you can say that there is some level, as I have told you, of meibomian gland dysfunction. It's a mild level and some level even of blepharitis. Therefore, this patient needs a careful analysis and ophthalmological analysis to define a treatment of the blepharitis and the dry eye. Okay, they don't have to, because sometimes I have to tell you that this happens with dry eye patients, as they have a lot of symptoms and they are not seeing very well. They don't know what is the problem, and they think it's a problem is they are not seeing well. When you put a refraction, they are seeing well, but they are still symptomatic, and this is the problem. Okay, let's go to the research. Here, we finally evaluated 58 eyes, 30 right and 28 left eyes, so 58 subjects with this in age of 48.8 years. And we created 2 groups, the dry eye disease group including 34 eyes, or 34 subjects, with this mean age, 52.2 years, and a control group of 24 eyes of 24 subjects with a mean age of 44 years. When we evaluated the baseline conditions, you can see here that there were no differences in terms of refraction, visual acuity, only in the OSD questionnaire. It's normal because the group of dry eye has more symptoms. It's normal. Also in knee boot 50%, but not in the first knee boot. This is important. And also logically in the fluorescein record time, and also in temporal conjunctival staining with more staining in the loop of the dry eye, and as can be, the rest of things are very clear. You can see here that most of our samples were evaporative dry eyes, or with a clearly evaporative component, because you can see that the Schirmer test production was very good. Okay, and we make a ROC analysis to detect which is the best test for the detection of dry eye. And you can see here that if we use the tear meniscus height, we have a cutoff point of 0.29 millimeters, and the sensitivity and specificity is about 62% and 67%. It's okay, but probably it's not so sensitive and specific because most of our samples were dry eyes with evaporative component. But you can see the first knee boot that we have a cutoff point of 5 seconds, as we said before, with 85% of sensitivity, but the specificity is not acceptable. I think the best of all was the use of knee boot 50%. Here we have a cutoff point of 7.35 seconds with a level of sensitivity 65%. Could be better, but it's okay. And the level of specificity is quite high. The good thing is that we can combine the three parameters, and probably this is what we are doing now in a logistic regression model. It's what we would like to do in the future to obtain a model of prediction still better. But you can see from all these parameters, according to the statistical analysis, I would recommend the use of knee boot 50%. Regarding the comparison between the knee boot, the first knee boot and knee boot 50 with the conventional measurement of break time with the fluorescein, you can see that the mean difference is not very high, 1 second in one case and in the other case around 2 seconds, but the problem is the level of interchangeability between tests was very high. You can see that there is a level of potential variation of more than 5 seconds, and this means that it's not acceptable. But you can think about it that the measurement with fluorescein is completely variable and extremely subjective. Indeed, the first knee boot was significantly lower than the fluorescein boot. It detects earlier the first break because with the viewing through the slit lamp it's more difficult to detect the break of the tear film. And regarding the knee boot, 50% is significantly higher than the fluorescein breakup time. It's the opposite. Okay, and in conclusions, it's true that this instrument is, for me, is a very good device to be used in a clinical practice because it's optimizing the resources, because you are going to detect those cases that can need a more comprehensive analysis. You don't have to make too many tests to all patients because it's very time consuming, tiring for the patient, and I think this is more appropriate and not so tiring. It's very fast, the procedure of measurements. Concerning the parameters, it's true that the knee boot 50% exhibits better diagnostic capability for dry eye diagnosis than the first knee boot and tear meniscus height. The acceptable values of sensitivity and specificity make this parameter a useful tool for dry eye screening even. And it's important to say that the tear film measurements obtained with this device cannot be used as interchangeable with those measured with a slit lamp. we cannot make this. If you, it's better. We can see that the level of variability is lower with this instrument because it's an objective measurement compared to the other one. And important, the cutoff values obtained in the current series cannot be considered as applicable to other systems measuring the same parameters because it's the algorithms of detection of the breaks of the tear film are very different according to the instrument. And I hope you have enjoyed this talk. Thank you very much for your attention. This is my email address. If you need anything or if I can help, I will be pleased of helping any question on any thing that you need of me. Thank you so much.